Very happy to welcome Marc Schee to speak first. So Marc works for Alstom Medical. He's been with us for a good few years now, head of clinical science. He's got 10 years experience in the field of volatile biomarker research. His PhD pioneered the use of exhaled breath analysis in lung cancer, asthma, colorectal cancer, amongst others. Marc's a trained medical doctor, which helps us here at Alstom prioritize medical applications as a primary interface between clinical partners and Alstom. He also holds a medical degree and a doctorate in biomedical sciences and 10 PhD by studying use VOCs for diagnosis and monitoring. So Marc, over to you. Thanks for the time.
Thanks again for the intro. And like Billy said, I'm quite sorry we have to do this remotely, although it gives a bit of a unique insight into everyone's office or living room. What I'll be doing over the next couple of minutes is give a bit of a context to the utility of breath research in the context of the coronavirus pandemic, and also touch upon some of the things that Alstom has been doing over the past few months. So I think first off, it's fair to say the virus at this point doesn't really need an introduction. Despite its tiny size, it's had an impact on virtually every aspect of our lives over the past few months. And if we look at the spread of the virus over the past few months, actually, one of the striking things here is how rapidly this happened. This is obviously a consequence of the fact that the world is more interconnected than it has ever been. So I read somewhere that there were over 7 trillion kilometers flown in 2016. And that's why even in the first few months of this year, the virus spread so quickly across the globe. One important other aspect that should not be overlooked is the fact that this virus is one that actually transmits in individuals that are asymptomatic. And that is actually quite a critical aspect, because, for instance, if you compare it to the MERS virus or Ebola, those viruses are far more lethal, but fortunately, they don't spread as readily in asymptomatic individuals. So when we zoom in on that spread, it's important to just all be on the same page in terms of what the different transmission routes are that we see here. So first off, there's the direct exposure, so direct inhalation of respiratory droplets when someone's sneezing or coughing in your vicinity, and this is one of the main reasons why we're instructed to socially distance, to stay at least 1.5 to 2 meters away from other people. The second aspect is the so-called fomi transmission, so that's transmission via infected surfaces, typically the hand-to-face route. This is the primary reason why we're asked to wash our hands frequently. And the third one is airborne transmission, which the typical definition is through tiny droplets or aerosols that are exhaled or generated during medical procedures. And the sort of intervention for this is focused on wearing masks. And one of the somewhat striking things is when you start to look into these various routes of transmission is actually the fact that there's relatively little known about this last route of transmission, because it's one that actually is somewhat challenging to study. So that's why the WHO actually issued a statement urging people to look into more detail into the risk and modes of airborne transmission. So obviously the breath research community also answered this call, and I think many of you over the past few months have seen newspaper articles such as this one showing rapid breath tests that hold the promise of very quickly being able to diagnose the presence of COVID and very rapidly help us to return to normality. So I think it's fair to say that such a test that would be widely available and accurate and rapid would definitely be a game changer, because if we just look at two examples here with respect to early detection of an infectious disease is obviously critical to minimizing its spread. So if you look at the left-hand panel here, we see a situation where there hasn't been as widespread testing initially, and there's less of a tight control on these preventative measures that we just discussed. And the right-hand panel is a country in Southeast Asia where they have already, based on previous experience, have widespread testing in place and are more accustomed to abiding with the recommendations with respect to minimizing the spread. And you can see, just if you look at the y-axis here, that the numbers show a massive difference. So a very strong argument to develop a widely available and accurate test. But I think what is critical when you think about such a test is to really focus on, okay, what are you trying to establish and what is the purpose of this test ultimately? So I just want to focus a bit on sort of the biology of the virus and talk about this in that context. So given what we know about the spread of the virus and the fact that people are contagious prior to them actually having symptoms, and some individuals not developing symptoms at all, if you want to identify who actually may be contagious, you need to focus on an aspect of the virus itself. So that's typically why people focus on PCR tests. The virus utilizes actually the molecular machinery of the cell it infects. So it doesn't have its own unique metabolism, at least that hasn't been unequivocally demonstrated. So this actually means you end up in a situation where detecting of specific VOCs is actually quite unlikely to detect the presence of the virus. And that has important implications, because diagnosing the presence of this virus, and therefore someone that might be contagious, is probably best done through a PCR-based test. However, when it comes to the response to the virus, so actually COVID, so the disease induced by the virus, that's where your immune system is far more relevant. There's more and more evidence to suggest that some people who have actually very substantial responses of the body, actually at the point in time when they suffer from this cytokine storm, have very low viral loads. So that would indicate you would struggle to use the detection of the amount of virus to actually make meaningful predictions about patient outcome. However, I think, as we've seen from, for instance, the talk of Salman in the previous session, that if you start to zoom in on the immune system and the endogenous response to such a virus, you actually may be able to have a far more meaningful way to tell something about the response of the host. So in summary, it's almost thinking about, am I detecting the virus or am I detecting the disease caused by the virus? And that's quite a critical distinction you need to make when you think about where a test would be most useful in practice, and therefore also how you would approach the research. At Alstom, we think about BREF and we focus on sort of two main components of BREF. First off, there's the VOC fraction, which I think most people are well familiar with, that we focus on that and is the core focus of many of the talks at this conference as well. So these are the axial metabolites. But secondly, there is the respiratory droplets or BREF aerosols. So these are the non-volatile particles. And as we've discussed earlier, this is actually one of the primary transmission routes of the virus. So capturing these may actually hold relevant information with respect to the spread. And the receivers actually allows you to collect both of these samples. So first off, and most of you will know that, there's the BREF biopsy cartridge. This captures the exhaled volatiles onto these tubes. And secondly, there is the mask here, which contains a filter. And that filter allows you to actually reuse the receiver also in the context of the coronavirus pandemic, as long as you follow appropriate cleaning measures. But the reason that is possible is because it very effectively captures those exhaled aerosols and respiratory droplets. And I'll show you some data to that effect later on. But that actually means you're collecting two samples. And as we've just touched upon when we discussed the biology, the way we look at it is when you try and make a meaningful inference about COVID, the presence of the disease induced by the virus, probably a VOC-based approach is one that is the most attractive one. When you're thinking about detection of the virus. So to determine if someone would be contagious, probably collecting these aerosols is a most sensible route forward. I'll very briefly touch upon some of the considerations around using VOCs, and then we'll pivot towards focusing mostly on some of the work that we've done in the context of exobreath aerosols. So as some of you may be aware, we've recently launched our respiratory panel that focuses on the core compounds that have the strongest evidence around them in terms of being useful for the quantification of respiratory inflammation. And some of you that may have heard the earlier presentation of Pierre Hughes may remember that, for instance, includes compounds that allow you to differentiate between eosinophilic and neutrophilic airway inflammation. And that neutrophilic airway inflammation is something that has proven to be very relevant in the context of COVID. Therefore, when we think about using VOC analysis, on one part, there's obviously the discovery focus, but secondly, this list of sort of high quality candidates with evidence behind them are an interesting approach to pursue. A second thing that I'm throwing out there also to I guess evoke some discussion and to hear what the community thinks about these types of approaches, it is actually considering to using an EVOC probe type approach. So the virus is actually known to have specific proteases that it requires to actually leave the cells it has infected. And because it's part of their life cycle, it's actually one of the drug targets for a drug that Pfizer is developing. So conceivably, you may be able to develop a probe-like strategy targeting the same proteases, creating a situation where you would actually create a volatile signal that is related to the life cycle of the virus as a potential approach to investigating this. I'll now switch to the work we've done in the context of exhaled breath aerosols, so the second part of this slide here. And when we think about the utility of exhaled breath aerosols, one of the key observations we made, especially early on in the pandemic, was, like I mentioned before, these challenges around access to testing, and actually the conundrum that governments face currently when someone has a suspicion they may have COVID. That is actually when they go outside, they go to a testing site. There's going to be a lot of other vulnerable people that are part of the risk categories. There are nurses, there's critical staff there that may get infected. So if you have a reliable method of doing at-home sampling, that could make a very big difference. And that's sort of one of the key areas of focus that we're exploring in terms of using a exhaled breath test for the detection of COVID. So the basic principle is to allow people to do an at-home test, so that will just be the mask of the receiver, the silicone mask with the filter in it, not the rest of the body of the receiver around it. The filter could be shipped through regular mail and then would be run through a PCR test. So we've gone through the motions of validating this concept technically, and we're currently involved in a study to also validate that in a clinical context. To start off with, how do you capture these aerosols? I'm no physicist, so apologies for the physicists on this call for my oversimplification. But basically, there are two main ways. There's an impact collector, which is basically a obstruction in a flow path, and there's collision that occurs with this collector, and you can then afterwards rinse off these captured droplets. And the other approach is to use a electrostatic filter that sort of within that electrostatic field captures these small droplets. Our initial approach was to think, okay, what's the simplest collector that we can build? And when we did initial evaluation of a readily available impact collector, this is some of the validation data that we found. So this was a small pilot study where we looked at collecting a nasal swab and an oral swab, and also the impact collector. So individuals were instructed to cough 10 times into the device, and subsequently the presence of the virus was evaluated. A red square indicates that no virus was detected. The numbers inside the cells here indicate the CT values. So for those of you not familiar with this measure, the higher the number, the more replications are needed in a PCR, so the lower the original viral load. And what you can see overwhelmingly here is that in none of the impact collectors, the virus was detected. So there could obviously be various reasons for this, the breath collection approach, the extraction method, the efficiency of the collector, etc. And we've evaluated those approaches. And just one bit of data that I want to highlight here is the fact that the impact collector actually captured large droplets, but it was very inefficient in capturing the smaller droplets, while these are, at least from experimental designs, known to actually carry a lot of virus as well. On the right-hand side here is the receiver filter, and as you can see, there is a virtually 100% capture of the aerosols that were produced by our experimental rig. Subsequently, we set out to validate limit, to understand the limit of detection of our approach. So we took a lab-based approach where we aerosolized SARS coronavirus 1 and SARS coronavirus 2 in a controlled way to mimic exhalation of individuals and really understand, okay, what are the type of what's the limit of detection and what's the minimum amount that you would want to collect in individuals to evaluate if this would be a meaningful test. So what we did in this aerosolization is loaded 0.2 microliters of virus-loaded aerosols onto the filter, and that was subsequently extracted from the filter. And what you see here is the CT value. So again, high meaning a lower viral load, and the number of aerosolized virus particles here. And what we were able to show here is that the limit of detection was roughly around 50 virus particles per microliter of aerosol onto the filter. The same thing was done for the current coronavirus, and what we were able to establish here is that we could detect roughly 150 copies per microliter of aerosol on the breath biopsy collector. So all in all, that is quite encouraging for the use of the filter type that is currently in the receiver. One further aspect of validation for us was to look at the impact of storage. Obviously, for tests to be used in a meaningful way in an at-home setting, you want it to be robust against storage at room temperature. Ideally, you would want it to be able to be shipped at room temperature. So what we did is we loaded triplicate filters with the coronavirus and subsequently stored it for 24, 48, and 72 hours and assessed the CT values at each time point of storage. And as you can see in the plot here, there's no meaningful increase in the CT value for the first 50 hours, so giving us a high degree of confidence that we would be able to collect such a sample even in an at-home setting. Then a somewhat orthogonal way, we looked at the ability to capture a meaningful sample using the breath biopsy, respiratory droplets, and aerosol collector, was to look at sort of the wider microbiome. So this is a very preliminary pilot study that we've done with our partner in Biome in the Netherlands, looking at the composition of the microbiome in the nasal swab, the oral swab, and in the breath sample. And what you see here is every row represents a patient and every line represents an individual bacterium. So this heat map, when you apply a clustering technique to it, the interesting thing is that the clustering appears to happen based on sample type and not based on individual. If you were looking at a identical microbiome across these samples, you would expect a clustering per individual. Because we don't see that, that is an indication that there actually may be differential information in the capturing of the exhaled aerosols. And this is a topic we're looking into in more detail, because it would indeed be quite attractive if you could sample the deep airways non-invasively using the breath biopsy filter. Then with respect to the clinical validation that is focused on the coronavirus, I was hoping to show you some of the data today But I'm sure there's a lot of researchers on the line currently, and we've all been in that situation where everything's planned out in detail, but unfortunately during shipment there's an issue, and we've had the samples, they were damaged, and there's the potential for cross-contamination of samples. So our largest batch of samples that we wanted to include in this analysis was unfortunately not available at this point. So at a later point in time, we'll definitely be able to share that data. The trial approach we've taken is basically a non-inferiority trial to make sure we're not missing individuals with our sampling approach, because the main utility of it would be, like I described earlier, that it would allow individuals to sample at their own leisure at home, for instance. So this trial is currently running in Brazil, the UK, Netherlands, and Belgium. What I can share about preliminary results in a descriptive way is that we are now able to detect the presence of the virus on these filters. We do see higher CT values compared to a nasal swab sample. I guess that is to be expected, given what we currently know about the virus, that direct exposure is probably a more contagious route than exposure to aerosols. So the next steps for us will be to obviously recruit a larger sample size and do further validation. And I just wanted to end on a bit of a light note. When I was researching evidence around the ability of VOCs and also aerosols to tell something meaningful about infectious disease, I actually found this paper in the BMJ Christmas edition of 2001, exploring this other source of volatiles and aerosols, the human fart. And while on one hand, this is just a funny anecdote, there was a nurse in an operating theater that actually said, what happens if I would fart during the operation, and am I contaminating the operating theater? And as bizarre as a question it may seem, no one has ever researched this. So they did a study and they had people fart onto petri dishes, both with and without clothes, and were able to establish quite effectively that wearing a piece of clothing is a very effective way to prevent the spread of, in this case, bacteria. So obviously this is mostly a funny anecdote, but when you're thinking about the relevance of wearing a mask, this may be an interesting analog that comes to mind when you think about the efficacy of that. So on that note, I'd like to finish, and I'm obviously happy to engage in the discussion.
Okay, a few questions coming through. So just a reminder for people, use the Q&A function, not the chat function, when you're asking questions. So the first is from Ryan. If you suspect you'll only be able to measure the immune response of VOCs, is it possible to distinguish between different colds or infections? In principle, the immune response to different viruses, especially different coronaviruses, would be really similar.
Yeah, so I think that's obviously a very critical question. I will not answer that question in detail, partly because I think Paul Thomas will touch upon that in his talk as well. I think he's done one of the most interesting studies in that context, and especially it's these types of studies that you need to do comparing to other respiratory diseases. What I can say is that intuitively, I think you're right. You're probably looking at a test that can differentiate, are you ill from are you not ill? The nuance I would add to that is that different viruses and bacterial infections, etc., have different molecular mechanisms, different toll-like receptors, different immune activation pathways. If you get to sufficient resolution, I'm relatively confident you could differentiate between, for instance, a viral and a bacterial infection. But it's exactly those kind of questions I think people need to answer in research, and they need to make sure that it's captured in their claims.
I suppose with the bacterial, it has its own metabolism as well. So
yeah, excellent point. Yeah, with the bacteria having their own metabolism, which you could both probe and also measure, because a lot of bacteria have unique metabolites.
So there's another question. Interesting thing, there's an increase in CT value after 50 hours storage at room temperature. So genetic material is destroyed. How do you explain this?
So I think it is consistent with some of the studies that have shown the sort of viability of the virus on different surfaces. So I think this is purely degradation through environmental enzymes that are present. I think it may also relate to the inability to extract when the sample dries completely on the filter. There could be various reasons for this, but it is that timeline is actually very consistent with the viability of the virus on, for instance, plastic surfaces.
One from Anil, maybe Paul answers this one as well. Does the physiological process of human cell response in the respiratory tract in generating antibodies and T4 cells to fight invading SARS-CoV-2 generate specific VOCs? It's more critical to identify asymptomatic patients and already sick individuals. I suppose that's pretty similar to Brianne's.
Yeah. In many ways, it is simpler. I would give the context to that is when you think about preventing spread, detecting asymptomatic individuals is in many ways actually more critical. However, when you're thinking about utility in a hospital, for instance, it actually may be monitoring of the immune response that allows you to decide, do I take more aggressive measures in terms of treatment? Can I scale down a patient from ICU, etc.? So there would be meaningful use cases there as well.
Okay. Next question is the aerosol collected dry on a filter or wet, condensed into liquid droplets? Are viral particles stable on a dry filter surface?
Yes, so what the filter effectively does, it's capturing the entire aerosol. So the aerosol is this tiny droplet that will contain the viral particles. And like we just described, the capture of the virus and the droplet onto the filter shows to be stable to about 50 hours. I could intuitively think that part of the increase in CT value and the drop in sensitivity, therefore, would be related to the drying of the aerosol.
It's a question from Stephen here, Stephen Lamb. The 60-second test that the group in Singapore talked about, any sense of how that works? I presume it's a VOC-based approach is what they're claiming.
So most of those tests, and I think that's true for Graphonics and Graphomics as well, and the NanoSend test are tests that focus completely on pattern recognition. I haven't seen any tests yet that completely focus on a known metabolite with a very established performance for that metabolite. I do see there is a considerable risk there because you don't know what you're measuring. There's a big risk for population bias. Say you run a study in August and you say, hooray, I have 97% a negative predictive value of my test, but the actual prevalence of coronavirus was about 2-3% in your population, and there were no other respiratory tract infections at all, then yeah, that may very well be true. But how does that translate to a population in the current phase where people have all kinds of respiratory infections that may not be coronavirus? So I think especially with those tests, when you don't know what you measure, you need to validate it in the exact condition that you intend to use it. And probably you need to continuously evaluate it because there's a high risk of thinking you measure something, but actually you're establishing something very different there.
I think we have time for two very brief ones. Can you elaborate on safety measures for handling the filters?
Yes, so the filters can in principle be handled by the individual themselves, which obviously would pose no risk. When they're handled in a lab, they're handled effectively the same way as a swab is handled. So we do advise when people use it in a lab to do it in a fume hood. But in principle, that is not more laborious than sort of handling a nasopharyngeal or oropharyngeal swab.
So last one, is there a difference between the symptomatic and non-symptomatic patients regarding viral load?
So the patients, so that's one of the questions we'll answer actually in this current clinical study. What I think has been established is that there's actually the patients with the highest viral loads tend to be the ones that are early on in their infection, actually sometimes the asymptomatic ones, which again points towards that point that we need to be able to detect those asymptomatic high viral load individuals, because they're probably the super spreaders. They don't worry about being ill and they go wherever they want to go. When it gets to the people that are clinically ill, the viral loads tend to be somewhat lower, but the physiological response is much more important.
Excellent. Okay, so a few other questions. They'll be answered in written follow-up